Good morning and welcome to our monthly webcast. I am Samir Mehta, your moderator. This is session number 74. We'll take you through a multi-vessel complex bifurcation case involving the LAD and the diagonal and the left posterolateral branch. And before I take you to the cath lab, many of you have asked us about downloading and streaming with the iPhone app. You can proceed to the Apple App Store and look in for CCVVC app and download it. And the archived cases, of course, then you don't even need an internet connection and you can view at your pleasure. With this announcement, let me take you to the Cardiac Cath lab where Dr. Sharma and Dr. Kinney are standing by. Anu, good morning.
Yeah, good morning.
Good morning, Sabine.
Good morning, and just to complete on the statement on your app downloading, the one issue comes down that soon you will be making the indexing, right? Because we have so much material now with the 74 cases. So for interest of people, whether they want a bifurcation or they want a calcific lesion or CTO, you'll make there's some index was there before, but I think with the 6 year of work, we need to update that indexing because that people ask that which case I do go. So I think some of the important one, we need to sit down and just make it accordingly, like patients with impala, patients with the bifurcation, rotablation, orbital atherectomy, and so on and so forth.
Absolutely, that is vitally needed and it will be urgently put there.
Yeah. Okay.
So, as per the demand, another bifurcation case?
Yes. And particularly a lot of imaging work being done here. So this is the case. We go to the slide quickly. Our usual. These are our disclosures. Nothing has changed. This is a 62-year-old male. It's a little different type of case which we are presenting today. It's not our usual one, stable angina. This patient had a non-STEMI a few weeks ago, and cath revealed 3-vessel disease with a thrombotic culprit being RCA and other lesions LAD diagonal, which will show with a mild LV dysfunction because of inferior wall hypo. And of course, syntax score was 16. Patient had PCI of the culprit vessel mid RCA. So this is the non-STEMI. And of course, patient is a good medical therapy as shown below. And of course, question always comes that what do we do with the clopidogrel versus the newer P2Y12 inhibitors like ticagrelor or prasugrel, unless there is contraindication. I think more and more we are relying on that. So clearly, Anu will take you through that what was done in this particular case in the right coronary PCI.
So if you see the LV function is near normal, he presented with a non-QMI and had a thrombotic RCA, which we had to do thrombectomy and a single stent, which looks, this is what the RCA looks like right now. On the left side, we have a left vein which is non-obstructive, but you have maybe a moderate, about 60-70% disease in a large branching LPL, if you can see it in this. And then we have a bifurcating prox LAD. The lesion starts in the prox LAD extending into the mid LAD and a significant disease of moderate size diagonal. If you see that, it's probably like a 0-1-1 kind of a bifurcation in the LAD diagonal.
So now question comes, and that's a very relevant question, that you don't have the stress test in between, and you know it's too early to understand patient symptoms because everybody had a little bit of chest pain, shortness of breath, and what to do. So we felt that it will, there is a trial actually done to answer that question. While we have a 2 randomized trial for the STEMI patients, which is clearly the latest being the culprit, and showing that the prophylactic PRAMI and culprit now that's showing that better of the multi-vessel PCI compared to culprit vessel. There is a trial done for non-STEMI patient called SMILE. Has not been published yet, but was presented in the ACC, and that showed also that one-stage multi-vessel intervention was better versus you do a stage multi-vessel intervention. But we felt that in this case, it will be appropriate to incorporate the physiological assessment, that is a FFR guided intervention.
Well, that seems a very appropriate FFR for both the LAD and the circumflex.
Yeah, exactly. I think that's what we'll do, and that is our plan. If we go through this, go back to the slide again. I think first thing we should do for the LPL, which likely will be negative in my opinion, although we'll be surprised because it's a large area of the vessel, even 60-70% lesion, and we'll go with the 0.8 cutoff. And of course, the patient, because no stress test, is on medical therapy and 2 vessel. So although it's U, but if FFR, we do FFR guided, then it will become the stress test or positivity. So it will move up in the same category to the appropriate. So now, and you want to do the FFR of the circumflex?
We'll do it.
Yeah.
As you're talking.
Yeah. So that we are going to do now the FFR of the circumflex while continue.
What's the ACT?
Okay, we are waiting for the ACT now. So meanwhile, the 2 important topics, I always try to give the latest data of in our field published in the, clearly one is the predictor of side branch occlusion during PCI, and the recent data on the treatment of ISR, particularly I would say very conflicting kind of results of the drug-eluting balloon in this setting. And the side branch occlusion, there is lot has been written about both pathologically, morphometric and various invasive and non-invasive studies that where the plaque occurs in the side branch at the divider, flow divider, usually on the lateral wall, and where the plaque is predictor of the side branch occlusion. It seems to be that if your plaque is outside on the lateral wall, more chances of the plaque shift into the side branch and causing the total occlusion. And this actually has been shown all by the autopsy studies also, that you have more plaque on the outside and then you have a stent uncovered at the level of carina, both DES and BMS, of course DES more, and of course you have a little more thrombus formation in those areas. So this is the landmark, this was the landmark study, which is the CORBIS 2 registry, coronary bifurcation stenting with the predictors and outcomes. And basically what we learned, the side branch stenosis, the main vessel stenosis, and side branch lesion length, borderline, acute coronary syndrome, and the non-left main intervention. So basically those are the one causes the side branch occlusion. And of course we also know once you have side branch occlusion, you have a higher MACE rate at follow-up, death, MI, and subsequent revascularization and MACE. Now they have presented the 3-year data, similar type of results, but more importantly, I wanted to give you the latest one, and that is they came up with the resolve scoring system of the 1600 patients with an angiographic tool for risk prediction of side branch occlusion in coronary bifurcation intervention. And it's very interesting that of the 1600, the no side branch occlusion occurred in 1431, means about 93%. 7% has side branch occlusion. So in 114 patients and with 118 bifurcation lesions, and of them, the majority of them were TIMI 0 flow, 70%, and about 30% was a TIMI 1 or 2. And what happened is about 10% improved spontaneously. You give vasodilator and so forth, and they did a PCI in about 7% of cases, but remain occluded. Over 80% of these side branches remain occluded. I am going to come back to this point that why it happened. In other studies have shown CORBIS about 54% remain occluded. So about anytime you close the side branch, the data are that about half you retrieve, 50 to 80%. Other remaining you cannot retrieve. 50 to 80% will remain occluded. That despite your attempt, you will not be able to open it. Now, these are the various baseline characteristics in this resolve study. The no side branch occlusion and side branch occlusion. Similar that acute coronary syndrome has more side branch occlusion, and the same where the lesion is the Medina classification, your side branch lesion and main vessel obstruction associated with higher predictors. Now, very important was the procedural characteristics, that if you did a PTC of the side branch, then of course you have a high side branch occlusion. At the same time, some studies have shown that PTC of the side branch prevents side branch occlusion. But if you have dissection of the side branch, then of course you have a higher occlusion. More important is, as you can see here, that if you have you did a side branch pre-dilatation, that there was less side branch occlusion. Very important was the jailed wire in the side branch. See, the jailed wire of the side branch was used barely in less than 20% of cases, 20-25. So it was not a routine practice with these operators to leave the wire in the side branch but even then, the side branch wire protected your side branch occlusion. So this is the very important, and that only goes back to this 80% they left alone or could not open it. It goes to probably because of the less use of the jailed wire, and I'll come to the editorial by Colombo on that issue. Now, what these investigators do, they basically went up and came up with a scoring system for each variable, and basically assigned the numeric variable, and come up with a risk model. Low risk, if you are 0 to 2, the score, 2 to if you are 3 to 9, it was intermediate, and more than 10 was high risk group. And they first made the validation data set of 1200 patients and came up with the occlusion side branch of 1%, 4%, and 18%. And then they prospectively evaluated that validation in 400 patients and similar data. So seems to be that this system does work and basically predict the side branch occlusion. So this is basically the latest data is. Now then there are other papers to show whether you do a various treatment strategy for bifurcation lesion, and there are two trials, the cross, basically whether you do a routine final kissing balloon or leave alone. These are data from Korea, or perfect study, crush or single stent. These are not the patients with the significant side branch lesion. If you don't have a side branch lesion, then of course they were in the cross, and if you have a side branch lesion, they went to the perfect trial, and basically showed that overall outcomes were equal by both the techniques, so that no matter what technique we use, nowadays our stent technology is so good, so it does not make any difference. Final kissing balloon dilatation does not help. So therefore, the question comes is that should we protect the side branch? And actually Colombo editorial really emphasized on this issue that yes, answer to that question is yes. Now, we start the okay. Maybe we can come back to this quickly. They did a FFR of the circumflex. Yeah, 0.79. Can we show that? Yeah, right there. Good. Okay. Good. Now to our surprise,
which is exactly what you had mentioned. Yeah. It's a large territory.
Large territory. So that circ stent, what is the plan now for the circ stent?
I think we can direct stent it or pre-dilate it.
Yeah. I think this can go to direct stenting. You stop it now.
So stop. He's symptomatic now.
Yeah.
Okay, sir.
Yeah, this is the circ. It's a long, moderate lesion. And the question is, do you go before the bifurcation?
Stent across.
Yeah.
That is a 3-0, right?
No, it's a 3.5.
I wish we had a mechanism we could have polled the audience, and I bet you most of them would have said, leave it alone.
Yeah, actually we, in about 1,000 plus cases of the intermediate lesion like this, one of our fellow working, you need Promus premium. Yeah, fellow is working on, come with a predictor that what really made it is the vessel size, the lesion length, or associated patient at MI, or so and so forth. So we really come back to that point, analysis, deep down analysis taking place. So that clearly we are going to put a stent, and then we'll come to the LAD, and that will do a live FFR. We go back to our slide. Then question was, very recently they presented a new technique for the coronary bifurcation, and basically have a single string. It's of course first the in vitro. Basically you put a stent in the side branch, which is protruding about 2 millimeter in the main vessel. Then you put a wire. You take the side branch wire out, and just at the ostium, you go through the last string or first string of the stent, basically, and then of course you do rewire the side branch, do a dilatation, and followed by kissing balloon, and then put a stent. So basically, you see that string, single or double string of the stent strut covering. You could say that this is a micro culotte, and they have shown the one experimental in vitro and about 11 cases with the good results with this technique, that yes, you have full coverage, and then it kind of really abut your side branch stent with the main vessel stenting. So now we go to the second point, and that is the treatment of ISR, particularly role of the drug-eluting balloon. As we all know that with the stent, all in-stent restenosis is your intimal hyperplasia. So therefore, we always focus to take care of the intimal hyperplasia which we do by mechanical means with a balloon angioplasty, with a cutting balloon, and of course used to do DC in the past, but then rotational atherectomy, maybe orbital atherectomy, and of course some cases you can put another stent to open the vessel lumen bigger. But drug-eluting balloon to prevent subsequent intimal proliferation has been used for this purpose, and of the various techniques for the drug-eluting stent restenosis, drug-eluting balloon will be the focus of our discussion, because that led to some of the articles in last few months. Now, as you know, at the same time that the drug-eluting balloon has been very successful against your standard technique in the femoropopliteal disease. We have two trials, Levant, actually Dr. Krishnan from Sinai is one of the lead enroller, and then of course the Impact SFA, which showed the utility of the drug-eluting balloon in treatment of the peripheral arterial disease. But question is, what about the coronary artery? There is a lot of data on the drug-eluting balloon, and basically mechanism is very simple. The one is the balloon, acute mechanism is the balloon angioplasty. That the intimal hyperplasia you cut by the balloon, cause the micro fractures and so, and on long term you have a positive remodeling and thinning of the neointima. Studies have shown by the FFR, IVUS and OCT that after the initial your balloon dilatation, you create the micro and macro cracks in the intimal hyperplasia with the drug-coated balloon, and then subsequently the intima thins out and give you a very smooth, dependable lesion for ISR treatment of the drug-eluting balloon. And of course, the initial data was very good when they compared against the balloon angioplasty. I also want to emphasize that drug-eluting balloon in the native vessel, again DES has failed in the coronaries, so that's not even part of the discussion. Discussion is drug-eluting balloon in ISR, whether bare metal or DES. And of course, the studies have, if you compiled here, you can see that against balloon angioplasty, drug-eluting balloon compares very well with a lower TLR and subsequent myocardial infarctions and restenosis. Classically, the PEPCAD-DES, even in the DES restenosis, that the drug-coated balloon is associated with a lower event rate, and the total, actually this one, binary angiographic restenosis, it should be the other way around. The first one should be the drug-coated balloon, and in the green should be our POBA. So clearly that it has been shown to be a lower restenosis by using the drug-coated balloon. So now what we have in last few months, one is the PEPCAD China ISR trial showing the paclitaxial coated balloon versus paclitaxial eluting stent, comparing now not with the balloon, now we are going to the drug-eluting stents. So once you compare with the drug-eluting stent of the first generation, one of them was the PEPCAD China ISR, it showed that TLR was slightly lower with the paclitaxial eluting stent and compared to a paclitaxial coated balloon, but overall outcomes were, as you can see, particularly there was a lower MI with a paclitaxial coated balloon. So it seems to be that yes, the DES works a little better, but overall there was no clear benefit of one technique versus other. So then we have the ISAR-DESIRE, which was a 1 year data presented 2 years ago, that you have three techniques: paclitaxial eluting balloon in red, paclitaxial eluting stent in blue, and then yellow being the balloon angioplasty. And you can see there that balloon angioplasty for the ISR does not work. Now question is, which is better, paclitaxial eluting balloon, PEB, or paclitaxial eluting stent, first generation? And basically showed that, as you can see here, there are slightly numerically lower death rate with the paclitaxial eluting balloon. But again, once you go to the TVR, the paclitaxial eluting balloon fails to a paclitaxial eluting stent, similar with the PEPCAD. So it seems to be that overall the paclitaxial eluting stent was slightly superior from the TVR point of view, but overall MACE were identical, but clearly was the lower mortality. So now we have the 3 year data of the ISAR-DESIRE 3 presented just a few months ago, and basically showed that whatever difference occurred of the TLR was in the first year. After that, all three techniques have a similar outcome. But clearly, overall 3 years, the TVR was lower with the stent, second was the coated balloon, and the last was the balloon angioplasty. So now if we put it together, now if you go to the death and MI, the story is a little different. As you can see there, at 1 year and even continued, that you have a lower death and MI in the paclitaxial eluting balloon group. So little, I would say, discordant result. Lower TVR with the DES, but definitely lower MACE rate of the death and MI with a drug-coated eluting balloon, and that leads to this results as shown here. The TLR numerically was lower with the drug paclitaxel eluting stent compared to a paclitaxel eluting balloon, but which actually have a very low death rate, significantly lower. But clearly they are all superior to a plain balloon angioplasty. Also thrombosis was half with the paclitaxel eluting balloon. So now this is our first generation DES, but we say, well, who uses first generation? Okay, so we have now two trials to using the drug-eluting balloon against everolimus eluting stent, which is the RIPS 4 and RIPS 5. And RIPS 4 basically is against in the drug-eluting stent of DES ISR, and about 300 patients showed that you have a better lumen with the everolimus eluting stent as well as a better outcome at 1 year. And this actually have put it together. So for DES ISR treatment, drug-eluting balloon failed against everolimus eluting stent, and you can see significantly lower TLR and TVR. Now you say, well, very simple. Why? Because the stent really gave you a bigger lumen. We have a bigger lumen, and then you don't have event rate with the newer generation stents. They did better at follow-up. Now similar data in the bare metal ISR using the drug-eluting balloon versus everolimus eluting stent, exactly identical data, so that DES is superior of the ES type, second generation DES compared to drug-eluting balloon. Then we have another, some signal in the same article, same issue of the JACC 2 months ago, that is that when you follow these patients, short term and long term, whether you use it for a BMS ISR or DES ISR, there's some story, different story happens. And that is what, that if you can see here, that you have a target lesion revascularization and the major event rate continue to diverge at 6 months or even further on after 12 to 14 months, you have another difference of event, much more higher in the, in a group patients who use a drug-eluting stent ISR compared to bare metal ISR. But all these patients received the drug-coated balloon. So key is that drug-coated balloon, some restenosis at acutely or 6 to 8 months, and then they have another at 12 to 18 to 24 months, and much higher in the DS group compared to the BMS group. So clearly showing the data that not only there is a higher restenosis of the a drug-eluting balloon, of course at 6 to 8 months or 6 to 12 months, but even there is a late catch-up phenomena, you get a second wave of restenosis. So having these two set of data, one, you have a late restenosis, and secondly, the data from the RIPS trial, everything put together, that if you compare the drug-eluting balloon against the second generation stent, it seems to be that the drug-eluting balloon failed. Now you say, well, maybe because of paclitaxel, because we know for restenosis, paclitaxel is a bad drug compared to sirolimus or limus analog, and maybe now we have the soon we'll have the drug-eluting balloon with a sirolimus and everolimus drug, and that may have a little different data. So this actually put as a Colombo put the editorial that is a drug-eluting stent the default treatment strategy for drug-eluting stent restenosis. The answer to that is yes, based on the data. So at present you have a DES ISR, best treatment what we know now, that you put another DES, unless it's a mechanical region, unexpanded stent, or you miss the lesion. In those cases you may just go to a high pressure balloon dilatation. Otherwise the treatment of DES ISR is re-DES as far as we know. What will be the great is your bioabsorbable vascular scaffold, that in that it's a great advantage that you don't take any lumen out, and of course this will help in many of these patients treatment once it will be available. With that note, we'll just come back to the case presentation now, and Anu has done the stent in the LPL and will take us through that. Anu?
Yeah, we just pre-dilated it and did a direct stent. Pre-dilated and then did the stent.
3U38, is that what you ended up using?
Yeah, the thing is both the OMs. See, there was a small OM and the large one. This was a slow flow with some EKG changes. So we lost that small OM2, I would say, and then the OM3. But just with vasodilators, everything got better. But the small OM is actually gone now. But this was just with the vasodilator.
Maybe give a little 2B3 bolus, it will come back even faster. Liquid, I call it liquid stent. But anyway, how is the patient doing? So we go to the then LAD.
Yeah, EKG is back to normal now.
Okay,
Yeah.
one more picture.
Right.
Yeah.
So, Samin, based on what you presented today,
Yeah.
what was the factor there which could have predicted the side branch? Of course, it's a small side branch closure.
I think if you have done imaging and you understand if there is truly a plaque, which could be that there is a plaque, whether it's obstructive, non-obstructive.
Again, probably on
yeah.
the lateral segment. Huh?
Yeah. I think this is the main vessel plaque probably causing it. In this particular case, that on the opposite wall of the side branch, the main vessel. But anyway, everything looks good. That a small capillary branch of the OM1 will come back, in my opinion. We get a 2 bolus of integral.
We'll see.
Yeah.
Usually,
Yep.
Samin, there have been a few questions which have come up, which I'll ask you.
Yeah, then give FEN.
Yeah.
Yeah, actually in this patient, very interesting, patient being Asian and has a, no, give FEN, 30 milligram. So in this particular case,
it's not working, give 60.
The bolus will be okay. Yeah. That in this particular case, we knowing that post-MI, I clearly believe now that whether STEMI or non-STEMI, enough data has accrued that for treatment of when you're doing a PCI, unless there is a bleeding risk, that always use the newer P2Y12, your choice, whether you use Procedural or ticagrelor. So in this case, just for a curiosity, we did FFR. Patient was on, we did ACT. Patient was PRU. We did a PRU, and patient was already on clopidogrel, was given loading dose of 300 milligram this morning, and despite that, the PRU was 290 or so, means way above our 238 cutoff. So therefore, now what we are going to change is give a additional bolus loading dose of the Procedural 30 milligram, just based on the trilogy trial that patients who were on clopidogrel, when they went to the cath lab, they gave 30 milligram bolus, and of course you follow 5 and 10 milligram based on the patient's weight and multiple use of stents. So this is what we are going to do, and we know that there was some side branch closure, patient has a small chest pain, we may decide to give 2B3A, but that still need to be seen. So now, going with the
going to do the FFR of the LAD.
LAD and diagonal system now, so going to the FFR of the LAD.
So what would be your prediction here?
Will be positive.
All right.
LAD.
Samin, in the meantime,
Yeah.
Let me get a few questions from the
We are
audience.
ready for
The first one is by Dr. Ajay. He's asking specifically, how frequently do you do IFR and what is its future?
Yeah, I mean, it's a very important, the reason is that IFR since had not made to the guidelines, so that we are not doing it because there is still a gray zone, and then in those cases you still have to do FFR. So we learned that in cases where there is a contraindication like patient with aortic stenosis and so, that you might need to do IFR, but we kind of had taken out IFR from our lab, but there is definitely some role in a selected number of cases, yes.
So now going back to the side branch occlusion, the real practical question comes, when do you leave the side branch alone? Are you going to really follow only the TIMI flow?
Yeah, that's a good point. I think what should be done, in my opinion, with the side branch, you leave the wire first. What the data to support that unless you have some imaging to direct you one way versus the other, it's the best your weapon or your armamentarium device is the leave the wire in the side branch, and that will prevent the side branch closure. That's one. So now then question is that after, and now we are talking about the side branch which is more than 1.5 millimeter,
right.
Very small. Like this case, we would not have left the wire into that small OM which closed. But in those cases, so now if the vessel closes, there is always, I say, if the patient came in with an open vessel, there should not be, we should make every effort, patient leaves the
positive
lab.
at 7 point.
Yeah, and FFR is positive again, we can show that. LAD,
okay.
Very quickly 0.74, and then maybe now do the diagonal.
Diagonal FFR? Please.
And clearly this patient has also moved into the appropriate criteria.
Absolutely, now became A. And that's a very important point, that because now it become a high risk non-invasive test, clearly, so therefore now if your side branch that came in with an open vessel, Now closed, if they're more than 1.5 millimeter, I would say always try to open it, maybe just with a very small balloon.
Right.
Wire it, give many times the the vasodilators, it opens up, then you are okay. You don't want to distort the stent. But definitely if it is closed, you need to go back and try to open even with a small 1.5 balloon. Just open it enough so that don't create a dissection, don't need to put a second stent unless it's a very large vessel. If it's a large vessel, then you should have a plan different way anyway with a two-stent strategy.
But what you are using the criteria to determine that is the flow.
Exactly.
Okay.
That is true. Yes. Or sometimes, you know, the patient continues to have this chest pain. There is 80-90% lesion, but the TIMI 3 flow, but patient continues to have chest pain. In those cases also will be that you will go back in. Now, what the stent jail wire does, two things wire do actually. One, that just mere presence of wire makes the angle little more favorable in terms of the plaque shift. So clearly that you have less side branch closure. Second, there is a foreign body in the ostium.
Right.
So all the snowplow effect will not suddenly occlude the vessel because there is additional material, and that will help, in my opinion, preventing the side branch closure. I know what are you doing?
Now we are going to wire the diagonal.
Okay.
But
Now,
just to go back to the question of how do you take care of the side branch, you know, when you are doing a bifurcation, whether there is disease, or I think first thing you need to look into is whether the side branch is diseased or not. If it's not diseased, then you know, the way to handle it would be something different. We just did a trial of imaging which is called the Orbit trial. The results have been done, have been submitted to TCT, so we cannot tell anything until we are going to accept it, and probably once it's accepted, presented, we will know the results, how to take care of this side branch with or without stenosis.
but most of them were no stenosis, no?
No, the trial we did was without stenosis,
Yeah.
but I think we have an algorithm how to handle this side branch.
Look, even without your discussing the results of it, I think viewers, if they have been watching it enough, have a pretty good sense of the algorithm.
Yes.
What wire are you using for the diagonal?
Yeah, this is the fielder wire. Okay. The LED has been done with the run-through, and then going with the fielder. Of course, it's a very short proximal LED and has to make a curve.
So, Samin, there are two more questions related to the drug-eluting balloons. In 2015, if there is a patient coming to you with the restenosis of either the a bare metal or a drug-eluting stent, your choice is going to be a newer generation DES?
I would say that up to a second or maybe third layer.
Right.
Yeah, and maybe the one difference would be that now patient cannot take the dual antiplatelet therapy for a long time. In that case, my threshold to go to drug-eluting balloon will be high, will be lower, and rather than putting a restenting. So clearly we know that in all these trials, your restent did better because they have almost 70-80% of patients continued depth for long period of time. So if there is a question about continuation of depth, then to me, I think that will be the case where will be the drug-eluting balloon will be useful. Second will be just truly a focal ISR. So now rather than you put it's a long stent, and rather than you put a multiple long stent again, it's a focal ISR. Give it one chance with a drug-eluting balloon, and rather than you put another cover the entire stent with the second stent. So that
even for that little focal one, you don't think a simple POBA can do it?
Yeah, that's actually, any study if you see with the current generation DES, even in the focal ISR, whether you do a regular balloon or you do the atherotomic cutting balloon or use a drug-eluting balloon, I think they all will be equal, along even with also with the DES. So therefore, I think real focal, whether in that case the drug-coated balloon will be little better than balloon angioplasty, I would say yes. Because I think every study has clearly shown that drug-eluting balloon works superior to a balloon angioplasty alone.
Right.
So
but
that's
really, for all practical purposes, we are talking about diffuse ISR, which is the real
for the
issue.
diffuse ISR, the answer is, so far what we know now, unless there is a depth contraindication, you put a new stent. And many times ISR occurs.
2020.
Yeah, 2020. First, you need to take care of the LAD lesion. You want
No,
to
but
do
the plan, you want to do 2 stent or
keep talking. Just say what's the strategy.
no? The strategy is same. This is barely a 2.2 vessel.
Yeah, why not we put the 2 stents here? Because it's a good size, long vessel.
Yeah, very large bifurcating diagonal branch. The lower of the two is a very sizable.
I think, it's coming at an angle. We just
Right.
cannot get the.
No, but that's okay.
You probably don't need it there.
But you have enough room
Get
there.
us a 2020, and then we can get a
No, but if you want
15. They get me a 2015 balloon, right? And then we can put a 20 stent there and
into
put a
the
long
diagonal,
stent in LED.
You'll dilate the diagonal first.
Yeah.
No, but the diagonal is a long lesion. You need to put a 24 or 28 millimeter, 2.25. Yeah, long.
We cannot, since we cannot wire the lower branch, you just take a
No,
20.
but you will be up to that, the bifurcation. See, there is enough room, 2 millimeter there. And go with the balloon. Once you do, you will be able to direct your wire better.
And if you would have gone into the lower of the branches, then you could possibly put in a longer segment there.
Yeah, but the question
Yeah,
is, I
it's
think
not-
we should stop
Exactly before the branch
exactly,
there.
yeah.
Yeah.
But you definitely attempt should be made now
No,
to bring the
24
wire
will-
into the sole branch.
And there is
24 will be too
enough
long.
room there
24
before the
will be good enough.
bifurcation.
2.2524 will cover that. But if once you go there, hopefully the wire will do that
long.
trick.
So here is another one more last of the series of follow-up questions. How many DES layers have you had in a patient who came to you?
Yeah, I have patients who have come with a 5 and 6 even. And you know our algorithm which we showed few years ago, that if you have a more than 2 layers of stent and patient has come third or plus time, we do a IVBT. So we do about every month, like today I had 2 cases. So we are the only one who does the IVBT in this area. So we get a selective referral for IVBT, and maybe wire has become straight now. We for refractory ISR, which is third episode with minimum 2 layer. But just to say the maximum, I have seen a case who had a 6 layer of a stent in that vein graft, 6 layers. Right. And every time you know that you put additional stent, your minimum lumen diameter will continue to decrease.
Okay, down.
But going away from the vein graft for a native coronary artery.
About 4 have been, I've seen many times 4.
So at what stage does surgery come back into play again?
Oh, many of these cases they already have a surgery. But you are right that I would say after third layer of stent, we by good heart, if patient has come back and requiring third layer of stent, I think we should think about sending that patient for surgery.
Right.
2 regions. Because even if you do the intervention on that case and then send for surgery, your results will not be good. Region, you have put up multiple layers. Sometimes you end up going very distally, cause more embolization, small infarction. So therefore, and from my point of view, for all practical purposes, you have a 3 layer of stent. Patient comes back, surgery has to be the main treatment.
Particularly if there is diabetes associated too.
You know what I'll do?
Looking very good.
No, take the run-through wire into the lower branch now. The LED you can always wire again. Let's try with the one wire there in the superior branch. So we try to use this, help of this wire. Want a whisper?
Yeah, that I was about to say that my choice here.
Get a whisper wire.
No, it's all, if once it's dissected, don't do anything, just take care with upper.
Whisper will be good. And particularly you have small dissections, whisper is a wire of choice, which we have shown many times in our meetings. And with those angulation, it's this looks like run through is not going to help, so you can put a run through back into your LED.
There we go.
Good. See, it got insult. Wire cannot be insulted. Good.
Just wonderful skills, rotating, switching the wires around.
Yeah, absolutely. So always use this double wires, which if one does not go, help with the second.
So back with the 2O balloon for the distal part of that, or
No, the question is, I think, let's go back and take
a look.
No, we can 24 millimeter stent will be okay.
No, his question is, if you're going to the lower branch, do you want longer?
Okay.
You want to take no, you have to balloon it again?
Yeah, no, not necessarily. You can go directly now. You want to make 28?
They actually have a 22532.
Yeah, you want 32? That's okay.
2.
Yeah, it's a Promus Premier, 2.2532. And what do you want for LED?
LED, I think 38, right? But then there's a bridge.
Yeah. No, I think we just go up till the middle bulge. 24.
Right here.
Yeah.
Don't take care of
the bridge.
Then you're getting into the bridge.
Yeah.
So for the
3534.
For the diagonal, you want to stent across the lower branch? Is that what?
No, upper branch.
Going into the
we are going
wire is in the lower branch now.
Right.
Yeah. So we'll stent into the lower branch.
Yeah,
Okay.
and upper branch will be okay. Now, question actually is an important point for the
Predilate.
LED.
Give me
Because
the 20
see,
balloon.
the view which we are seeing is showing it in the upper branch. That's why.
No, sorry. We just wanted to
You want
show.
to take a picture?
Yeah.
Okay, here we go now. Now we are in business.
Right.
Yeah,
Excellent.
see that?
Got it. Straightforward now.
No, we are going that. No.
3020 for the LED.
Okay.
I think we better pre-dilate.
Okay. Yes.
Yeah,
Always.
that may make it a
No,
little.
but you want a 38 also for the LED?
No, there's a
Cover it
bridge.
completely.
See that? There's a bridge. I mean, that's what we are thinking. Should we or no?
Yeah, although it's a bridge. See on the top?
The first picture.
Yeah.
See?
That's a bridge. Yeah.
You don't need
Don't worry about. Yes.
I think the discussion we are having is the length of the LED stent. So that's why we went to the first picture. So if you go there, the
Yeah,
length.
very prominent bridging there. In the mid
So
portion.
it never the stent. Because once you wire and you make it look like there's a lesion there.
So 24, 24 or something, 3 or 24.
Or 24. No, that's a no. This is the what
It's
you're
a
going.
3.
This is 3 or 20.
Yeah, for the LED.
Yeah. Fielder is in LED now.
So another audience question for you: which is your favored small stent?
No, the 225 comes both in Promus as well as Zions, but the lengthwise, I think the Zions only comes 225 28 and the Promus comes up to 32.
All right.
Now, other thing is the same. If you don't have 225, you can go 25 low atmosphere because if the stent is the same, balloon is different. Go at 8 atmosphere and then post dilate.
Samin, another question you've generated a lot of interest today with your talk is FFR reliable in acute coronary syndromes?
Yeah, actually,
Not in ACS.
Yeah.
Go.
Although some data are there to even in the acute coronary syndrome, but I think we believe that most of the data really practice changing is from the patient with a stable syndrome. But I would say the FFR, just to say, and I want to make it a very clear statement, I think the FFR of the non-culprit vessel in acute coronary syndrome will be true.
Yeah.
But culprit vessel may be different, but in the non-culprit vessel should be true. Although we know that in acute syndrome, there is a lot of the catecholamines and so on and so forth release, so that even in the non-culprit vessel, it may affect. There are actually papers to show that FFR of the non-culprit vessel actually usually does not change in a patient with acute coronary syndrome. So with that note, I would say that there should be no question in my mind that like this type of patient, so you have done the PCI of the RCA at time 0, and that's okay. That you evaluate your other 2 vessels at that time, so should you bring this patient back later because you didn't want to do all the multi-vessel PCI at that time. So that's a reasonable approach. But key is that FFR of the non-culprit vessel should be okay, will be predictive. So now let's talk about the strategy. We have taken the next picture.
Yeah, we have a 225 for the 32 for the diagonal.
Okay.
And then
let's go with the diagonal first.
I think 3.5 will be too big for the LED.
You can have
just
3.0.
got a
3.0 post dilate.
3.0.
3.024.
What's the stenting technique?
The question is that what is the stent technique? It was a Medina 011.
Yeah, so it has to be a V.
Just kind of a
So
V.
if it's a V, 24 may be too long for the LED.
Then 20.
20. 3 or 20 LED.
Samin, have you had the chance to use Cangrelor in any case?
Absolutely. Right now, as we are talking, I have a patient who is getting IV Cangrelor as a bridge for a non-cardiac surgery. This patient is my favorite patient for last 25 years. First time I dealt, actually, the 16 years. That since 1998. And had done an all-vessel intervention. He never wanted an insulin-dependent diabetic, never wanted cabbage, and so forth. And this person, about 6 years ago, needed a back surgery, and which was after 2 years of the stent implantation, and we stopped that time, was clopidogrel, and he developed stent thrombosis on day 4 before the back surgery. So required PCI, and of course back surgery was done, but on a very limited fashion. So now he has again multiple disc prolapse, very bare to walk, had even the foot drop, and now needs the back surgery. So therefore, what I did, he had been on, initially was on Procedural, but then developed a small CVA, so we changed it to Brilinta and Ticagrelor. And now, because of in preparation for back surgery, you know that you have to stop both the antiplatelet therapy. So we have stopped since Saturday, both the aspirin as well as Ticagrelor, and he has been put on the maintenance infusion dose, not the acute coronary syndrome dose.
Right.
The infusion dose of the bridge therapy on the Cangrelor. And they tell me that this is the first case in New York of this kind. That's what the medicines company told us yesterday. I mean, 2 days ago.
Fantastic. You're exactly right.
Yeah.
The doses for both these indications are different. Have you had the chance to use it for PCI?
Not yet.
Not yet.
Not yet. But now, since we kept it in the cyanide
formulary
now,
right.
Although it's still a non-formulary, which we are going to present. Sine?
So this is a V-stent, okay, about a millimeter carina only. See the two dots are closed. We didn't pre-dilate the distal part, that's why. I need to post it there,
Yeah, we can
right?
dilate
Okay.
Yeah, don't go higher.
Down. One by one, right?
Yeah.
So it didn't go one by one.
I mean, Carlos Nieves from Puerto Rico is asking, what's the plan? Single string technique?
No, this one is a 2. I
Two.
think single
This is a
string.
V-stent, yeah.
We're putting a V-stenting, and I think the single is...
His question came 30 seconds later.
Yeah,
Go.
yeah. The key was the single string. Actually, again, there was an editorial by Colombo who really said that we really need to see whether this is any greater advantage of this technique than compared to our other, that what really we are achieving by this single string. So I think the clinical data looks good, experimental, go simultaneous again. That
Very nice expansion. The distal part of the diagonal stent previously was not expanded.
Yes.
Now it looks good.
Yep.
So how many atmospheres was the last simultaneous?
The simultaneous was 12.
12.
Okay.
12. And individually we went up to 16 atmosphere, and actually 16 is the one which expanded the diagonal.
Right. At
Okay,
16,
ready?
you are looking at a 2.5 there.
I know.
We need a little, get a two balloon.
Segment
For what?
distal to
The diagonal. Maybe a
Diagonal,
little
yeah.
smoothing out, but everything looking very good. Right, nice expansion.
I think
full cover.
vasodilators will
And
take
you
care
are
of
happy
it.
with the proximal segment, proximal to the LAD
Yeah,
stent?
we
Yeah,
can take
yeah.
the picture other way, but the only concern me is a little bit of the distal, the diagonal,
Okay.
because we never dilated that area, 2O. Put a 2O balloon, just smooth out, doesn't require that you have to put another stent.
Well, also I think that that stent is now about 2.5 at
Yeah,
16 atmospheres.
exactly.
A slight
Exactly.
disparity in the size.
Yeah, and we'll give a little vasodilator. EKG is fine.
I am also told you had an exceptional and ultra brief TAVI case last week.
Yes. So this was our structural webcast. Was very, very good. And Evolute R is the addition to our core valve general family. Super valve does not move and it stays. Although it's hailed as a recapturable, but in none of the cases we needed to recapture because it just wherever you start, it stays there, and it's a 14 French. So that's remarkable. So you need only 14 French device. So that it's a great addition.
Big advancement, yeah.
And I know that Sapien 3 is available, but that may not be truly 14 French. But the key is that Evolute R is definitely a 14 French.
Look, in 2 or 3 years to gone from 22 French to 14 is
14 French.
Amazing.
Unbelievable.
So, I mean, another quick question for you. I'll read it exactly as it has been presented. What is the protocol for switching from prasugrel to Brilinta? Do you need to load with ticagrelor or Brilinta?
Very good point. Very, very good point. I can tell you.
And
that
this is Dr. Ajay from India.
Yeah. There is no clear answer for this question, although second question which I'll just phrase will be, but the patients in the Plato trial, that if you are on getting any of these drugs, for acute coronary syndrome they give 90 milligram and in the cath lab give another 90 milligram. So if you are bringing that patient in the cath lab and you already have the clopidogrel or prasugrel, you need to give 180 milligram of ticagrelor.
That's the important part.
Yeah, because it is the works on the different path. The pathway is not a ADP receptor; it's a separate receptor. So you have to give full 180 milligram dose. Now,
Looks
other way question.
Excellent there. In the meantime,
Yeah,
the last
excellent picture. And if you are already on clopidogrel, but now you want to put this patient on the prasugrel, the data actually we have exactly the data on the trilogy. That you don't need to give 60 milligram loading dose, you can give 30 milligram.
Right.
It works on the same platelet receptors. Even if you are you are non-responder, but remember that non-responder still you have some platelet inhibition. So by giving additional prasugrel, you really will bring the platelet inhibition to 60-70%. So 30 milligram will be good enough, and you don't need to give a bolus of 60 milligram or loading dose of 60 milligram.
Excellent. Both lesions look very nice, although in the last picture now I wondered if that proximal circ could have also been stented more for cosmetology.
Yeah, no, but we are decided. Remember with the 38 you had to be, if you look at the lesion was probably about 42 or something,
right.
You just have to be sure which one you wanted to cover.
Exactly right, and that segment looks beautiful, and there's a little hint of that occluded small OMB coming back too.
Yeah, you will see it already.
Hint. Yeah.
And I can tell you give a little, have we given integral or no? This is the case, we still have some EKG changes. The little bit of T-wave inversion in lead 3. Having side chest pain still?
So is integralin your favored drug at this point?
Yeah, I think to me, since we have the newer antiplatelet, oral antiplatelet therapy, the F6 has disappeared, even in acute MI setting. So there is no reason to carry that. I think with those cases, although tirofiban is making a pushback because of some of the trial.
Is it the quality of the results or the economics?
Yeah, I think probably both. The quality basically showing that subsequent studies have shown no additional benefit of F6, and definitely once you have a stronger antiplatelet therapy, there is definitely not much role. So with that note, we actually carry. Although some centers give tirofiban high doses, but we use 2 boluses of integralin 10 minutes apart, and rarely will give infusion. So 98% of the time it will be 2 boluses, and of that 98%, 2/3 is only 1 bolus, and other 1/3 we give 2 boluses.
But unlike epcicimab, this is just intravenous. You're not giving intracoronary.
Yep, just intravenous intravenous bolus. Now we can complete this quickly now because reaching to our time. If we can go back to our slide set with the take-home message of the today, or the predictors of side branch occlusion and the update on the drug-eluting balloon for the ISR. The side branch occlusion during PCI of bifurcation lesion occurs in about 8 to 10% of cases and remains occluded in majority if jailed wire protection was not used and is associated with higher MACE. Side branch occlusion can be predicted by common angiographic features such as main vessel plaque, side branch stenosis, but in the Resolve trial it was not the lesion length. And data supports that the jailed wire technique to prevent side branch occlusion is valid. Then the recent randomized trials and registry long-term data have shown the failure, particularly high TVR of the drug-eluting balloon in the treatment of ISR and higher MACE compared to newer DES in this setting. So clearly that while there seems to be some excitement in the beginning, but in the now with comparison with the DES, drug-eluting balloon, in my opinion, is inferior. Clearly, the use will be in selected cases of focal ISR, as we spoke, and also where long-term depth cannot be guaranteed. In that case, you don't want to put a stent in a stent sandwich, which may have a higher thrombosis rate. So we go to quickly our 3 questions, that what are the predictors of side branch occlusion as per Resolve scoring system, except that what is the false answer? Plaque distribution of the bifurcation of the lateral wall, pre-procedure main vessel diameter stenosis, side branch lesion length, diameter ratio between main vessel and side branch diameter stenosis before main vessel stenting. Second, ISAR-DESIRE 3 trial for ISR treatment showed the following results at 3 years. The drug-eluting balloon had lower TVR compared to DES. DEB has lower death and MI compared to DES. DEB has similar TVR compared to balloon angioplasty, and the DEB has higher thrombosis rate compared to drug-eluting stent. And lastly, the DEB has lower MACE compared to drug-eluting stent at 3-year data. And the last question of the day is, following statements are true for the trials of DEB versus newer generation DES for ISR treatment, except that higher TVR with the drug-eluting balloon, higher MI with drug-eluting balloon, higher death rate with drug-eluting balloon, lower TLF with drug-eluting balloon, or lower MACE with drug-eluting balloon. With that note, we conclude our today's webcast.
Where's the answer for your previous questions?
They're all on the webcast. You remember, people go back and get the answers.
It's all on the webcast, including the July case, which can be viewed now. Anu, any final words from you?
No, the final words, right, just to tell you, I think the bifurcation stenting technique that we used here, if you go back to the cine angiogram, since we have 0, 1, 1, for LAD and diagonal, I think the best way to come out would be a V-stenting, where your carina, which is in the main, you place 2 stents at the same time, and your carina should be less than 2 millimeter, which we used here, which was right.
There we go. Next one.
Yeah. Look at the 2 dots.
Yeah.
Yeah. 2 dots means this is a Promus stent, so your stent starts a little bit inside the dot, and this is how you would do it. So go with the simultaneous inflation between 10 to 12, and then individual go 12, 14, make sure the stent is well expanded. Here we had to go almost to 16 to the diagonal to make sure it expanded well. Then the final with about 12 atmosphere, and this is the result we have. Like you had pointed out, you know, the carina will look like this in since we have a 3A0 and a 225, just at the level of where your carina is. You can see it looks overexpanded, but that's the look we get. But as long as in your cordial picture, if you see here, it looks okay, that we have not truly overexpanded in the proximal part with the carina. And this is another view we took just to confirm that. What you need to be careful, that if you have seen it, that very rarely that you could have proximal edge dissection when you are doing this double stent technique. So that's why take 2 or 3 views to just confirm, which we did. Everything looks okay, and that's where we are.
Looks very good.
Anu, thank you so much. Samin, excellent presentation of a wonderful case. I want to also thank our audience for their very robust participation today. We'll see you during our next session, which is number 75 on September the 15th.